Thank you so much. So first, I want to thank everyone who helped to put this together and for the opportunity to present today. So of course, our obligatory slide, I have no conflicts of interest to disclose, and any discussions of drug use will be consistent with FDA use. I will say that maybe my only conflict of interest, as you heard before, is that my background is in nutrition, and that's how I came into this profession. That's how I chose endocrinology, and that's how I got into this project as well. So just a quick outline for what we're going to speak about today. We're going to start to discuss the evolving obesity epidemic in children, including those in East Harlem in our neighborhood. We're going to understand the need for nutrition education in mothers of children's ages 0 to 5 here in East Harlem. And we're going to review the project Recipe for a Healthy Lifestyle. We'll have lots of time at the end for questions, but if there's anything that you'd like to ask in between, please feel free to interrupt. So I think a lot of people here are from pediatrics, but they might be from other fields as well. And you don't have to be a pediatrician to know that childhood obesity has been a major problem. You see these kids on the street, you see them on the subway, you see them in restaurants. It affects all different ethnicities, although some disproportionately, like we'll talk about in a little while. So first, I want to begin on the diagnosis of childhood obesity and childhood overweight, since not everyone is coming from a pediatric background. We define this using BMI. Everyone knows what BMI is. Weight divided by the height, so kilograms per meter squared. In the adult world, we use straight up numbers. Greater than 25 is overweight, and greater than 30 is obese. In children, we use it a little bit differently. Instead, we put them on growth charts, which I'm going to show you in our next slide. So overweight is between the 85th and the 95th percentiles, and obesity is anything greater than the 95th percentile. These growth charts, like you see here, are very important in pediatrics. They're very important in endocrinology. So this is the BMI percentiles for girls. You can see here that I've highlighted the 85th and the 95th percentiles. You can see on the bottom we have age and how it changes with age. Careful measurements are also really important. You can imagine that if someone was to measure a child with their clothes on, with their shoes on, with things in their pockets, adding to their weight, and then maybe not so accurately measuring their height, they could get a very different BMI than what the child actually is. So in the next few slides, I want to review some of the statistics related to the childhood obesity problem. Here, this is a slide from the World Obesity Federation, and it shows the prevalence of childhood overweight from the 1960s through the 1990s. You can see the US is in kind of like a light pink, showing that we have 15 to 19.9% childhood overweight. And also note that much of the world is in that green-blue color, noting a very small percentage. Now compare this slide with the next one. This shows the same map, but in the 2000s. So you can see that basically all of North America is in this bright red color, indicating that we have greater than 24% childhood overweight. And the rest of the world has really changed colors as well. You can see that South America has increased, much of South America has increased to that bright red, Asia in the light pink, and even Australia in the red. So you can kind of see between the two slides how it has increased over this time. Moving on from the whole world, let's look at the United States. So this is a little bit different. This is just looking at obese children from 2011 by state. This is from the Data Resource Center for Child and Adolescent Health, a project of the Child and Adolescent Health Measurement Initiative. This measured children 10 to 17 years old, and you can see that obesity has become a major problem. I circled New York. We're in the light pink, which shows 10 to 15% obesity. And actually, when I looked at the tables at this time, New York State had 14.5% childhood obesity. I also want to point out you can see some disproportionate colors, right? A lot of the brighter colors in the South. Mississippi had the highest childhood obesity rate at that time. It was 21.7%, followed by Louisiana with 21.1%. So this slide is from a CDC publication. It's from the NHANES data, the U.S. Health and Nutrition Examination Survey. It shows obesity by age group. So here you can see in the yellow, the 2 to 5-year-olds, and we're looking from the 60s to the 2000s, and you can see how it's increased in all age groups. The age 2 to 5 I thought was interesting because there was quite a steep incline at the beginning of the 2000s and then somewhat of a decline. And it does show maybe there's somewhat of a decline, which could be some positive news. And yet when you look at the older ages, we're still quite a bit on the incline. And again, this is showing the prevalence of childhood and adolescent obesity. Here you see another chart broken up by age. This is from a paper from the Journal of the American Medical Association in 2014. All the way at the left, we have the 2 to 5-year-olds, followed by the 6 to 11-year-olds, and then finally the 12 to 19-year-olds. In the green, you see just the percentage of overweight, and again, that's BMIs between the 85th and 95th percentiles. In the light blue, we have mild to moderate obesity, and then in that purple, you see the severe obesity. And in all age groups, even in the 2 to 5-year-olds, you can see that it's still at very high rates.
Could you go back?
Of course.
Previous slide. Look at the blue, okay? That suggests that when that lip of increase in the kid, the 2 to 5-year-olds, go through puberty, they gain weight again.
Absolutely.
Is that right?
Absolutely.
Okay. Thank you.
Absolutely. Yeah,
so
you would.
There's a puberty.
Puberty definitely has potential, and I think you would also have thought with the decline, that slope on the decline, it would be mirrored in all the other ones, and you don't necessarily see that. This is from an article from the New England Journal of Medicine in 2014. They looked at a cohort of kindergartners, and they followed them from 1998 through 2007. In kindergarten, 12.4% of them were obese, and 14.9% of them were overweight. They followed them to 8th grade, where 20.8% of them were obese, and 17% were overweight. The greatest increase in the prevalence of obesity was between the 1st and the 3rd grades. And those who were the heaviest in kindergarten were the most likely to be obese by 8th grade. Really what this study kind of concluded was that a component of obesity is established in the earlier ages. And that's kind of where our program wanted to help. So now that I told you about the world, the US, and New York, let's look in our neighborhood, East Harlem. So East Harlem is defined as north of 96th Street, east of 5th Avenue, up to about 125th Street. It's predominantly Latino, and I was looking up some of the history of East Harlem while I was preparing this. And early in the 1900s, it was actually known as Italian Harlem, which I didn't really know about. It seems like there was probably some good stories at that time with some crime families running the neighborhood. But it really was after World War I that it began to be known as Spanish Harlem with the immigration. We know that in East Harlem, we have one of the highest concentrations of Puerto Rican families in New York City. There's 24 public housing developments, and some of the more notable people from the area include the singer Mark Anthony, the former mayor Fiorello LaGuardia, Langston Hughes, Al Pacino, Tito Puente, and Tupac Shakur. I had a good time looking up these things.
And my father, Bernie Barnett.
There we go. Of course. How could I leave that out? So childhood obesity here in East Harlem in our neighborhood. So more than 1 in 4. Yes. More than 1 in 4 children in Head Start and in elementary school are overweight or obese. Black and Hispanic residents of East Harlem are almost twice as likely to be obese as the white residents. And this is happening right here, right where the great Mount Sinai is. This is from a public health office handout and talks about obesity here in East and Central Harlem. And here you could see that at every age, overweight and obesity are common here in East Harlem. So at the top left, we have Head Start children. And there you can see 15% are overweight, 27% are obese. In elementary school, the numbers go up slightly. In public high school, the numbers go down slightly, and not exactly sure how they found that. But in adults, the numbers go way up. So by the time people are adults, we have 33% overweight and 27% obese. This is from a study that was done by our environmental health group headed by Maida Galvez here at Mount Sinai. And this was published in 2009. The map is actually from 2004. And the study showed that children living within 1 block of a convenience store were most likely to have a higher BMI. So the map, you can see the different types of stores here in East Harlem. This map kind of mirrors the one that I showed you before. The stars, hopefully you can kind of see them, those are the convenience stores. The diamonds are fast food, and the triangles, which I don't think you see too much, are actually supermarkets. And when they went around and they actually counted these things here in East Harlem, it was found that there are 168 convenience stores, 139 fast food restaurants, and only about 8 grocery stores. The colors on this slide represent BMI. So the brightest colors represent the highest BMI. And when you look at it, the brightest colors are the ones near the more convenient stores.
Where are the schools? That chart is available, isn't it?
I believe that it is.
Yeah.
I believe that it is.
Yeah.
So now we know all of these numbers and all of these statistics, but really, why do we care about this? So we know that there are significant morbidities associated with obesity, and it really affects all the organ systems, as you can see here. Pulmonary with sleep apnea and asthma, GI with gallstones and liver problems, the musculoskeletal system, the endocrine system, which I am partial to, with type 2 diabetes, and precocious puberty. And I also want to point out the psychosocial system. That's really important, right? It's almost like a vicious cycle. These kids feel bad about themselves because they're heavy. They tend to eat more. They feel bad about themselves because they're heavy. When I looked up the cost of childhood obesity, the Duke Global Health Initiative showed that over a lifetime, childhood obesity costs about $19,000 per child compared to a normal weight child. And at first I wasn't sure, I actually thought that number was a little bit on the lower side, but when I read a little bit further, when they did the math, they were saying that it could cost up to $14.1 billion. And that sounds like a good, a pretty hefty number to me. So here's a question. What is the most common underlying reason that leads to obesity in childhood and adolescence? Is it genetic predisposition? Is it excessive caloric intake? Lack of exercise, increased time in sedentary activities?
All of the above.
All of the above, absolutely. They're all really important factors.
Now you're just American.
They're all really important factors. But when we look at genetics, twin studies have estimated that 65 to 75% of the tendency to be obese is inherited. The heritability of obesity is greater than that in schizophrenia, alcoholism, and atherosclerosis. And then the remaining percents are attributed to various environmental factors. When we talk about the genetics of obesity, we're really talking about polygenes, not just one gene. Here we have a slide showing, quote, the simple math of obesity, right? Calories consumed and calories expended. So it's like a seesaw. The more you consume, the less you expend, the more you will store. Not quite as simple, we know from a lot of the studies, but that's really kind of the basics. We know that 3,500 calories is equal to 1 pound of fat. So if you expend an additional 3,500 calories, you can lose 1 pound of fat. Now we know that many things play into this, metabolic rate, etc. But again, these are some of the basics. So when you think about in and out, you can see here in the gray The rate of weight gain when calories consumed is equal to calories expended. Normal on this growth chart, right around the 50th percentile. If we think about someone taking in an extra 50 calories per day over their lifetime, you can see with this blue line that they're in the obese category. If they eat an extra 100 calories per day over their lifetime, you can see on the red line. It's pretty impressive. And when you think about an extra 50 calories, it's half of a small banana, it's 9 almonds, it's 2 pieces of cheese. An extra 100 calories is 10 carrots and some hummus, one of those 100-calorie packs. It's not much, right? But when we think about what it could mean, you could see here on the chart, it makes really big effects. I mentioned before about genetics. We do know that there are some genes that can cause obesity. And if you were at the Endocrine Symposium earlier this week, we actually had a talk about the genetics of obesity. These things are exceedingly rare. One of the things that I took away from the talk is how rare some of these mutations in these genes are. We do know that some medications can cause increased weight gain, some steroids or antipsychotics. We do know that there are syndromes such as Prader-Willi that can cause weight gain, and there are some endocrine causes that we see. But again, compared to what we are seeing with childhood obesity, these are pretty rare and likely not the cause of much of the patients that we're seeing. So what do we do, right? There's the question. Here you can see in all areas, in all levels, there's things that we can do. Prenatally and postnatally, we can make some changes. The family, eating together, or not using the television at mealtime, avoiding these calorie-dense, nutrient-poor foods. These things can all help the childhood obesity epidemic. Schools can make changes. They can review their school lunch programs, take away those vending machines. Communities can increase exercise facilities, and industry can change, right? Change their advertising towards kids and labeling standards. These are from the Endocrine Society, and they show some guidelines about basic treatment, basic lifestyle changes. Eliminate all sugary drinks, restrict calories, create a balanced diet, exercise suggestions, involve large muscle groups, etc. So, but when you really think about it, how are our families getting these suggestions, right? Is it at their well child visits with pediatricians? Well, from a study from Pediatrics in October of 2011, the study showed that about a third of well child checkups took less than 10 minutes. How is that pediatrician getting any type of preventative strategies across, right? 47% of them took 11 to 20 minutes, and 20% took greater than 20 minutes. But when you think about all the things that the pediatrician has to do during that time, when are they getting in some of these preventative strategies? So what did we want to do? We wanted to assess the impact of an obesity prevention program on knowledge, attitude, and behaviors in Hispanic mothers of children ages 0 to 5. So we applied for a Healthy Active Living grant from the Community Pediatric Training Initiative, a branch of the AAP. And some of the goals of the grant were to increase opportunities for children to be physically active, promote physical activity, and encourage consistent messages. In our grant application, you can see some of the goals and objectives of some of the things that we wanted to do, some of which we've done, some of which are still in progress. But we wanted to develop and implement a community-based obesity prevention program that uses home visits and parenting sessions led by residents and healthcare workers to engage families, residents, and community physicians and promotes healthy, active living. We wanted to improve family knowledge of the behaviors that prevent obesity and affect positive change in these behaviors. And we wanted to maintain or improve maternal and child's BMI, improve the quality of counseling and anticipatory guidance given to parents about obesity prevention, and also to engage local pediatricians and improve their knowledge of these behaviors that will promote healthy, active living. So after we received the grant, we approached one of the local community-based organizations here in East Harlem that serves Hispanic underprivileged families, Little Sisters of the Assumption. If you're not familiar, they're located on 115th Street between 1st and 2nd. They're an amazing group. They do things from advocacy, they have a food pantry, they do early intervention, they have preventative services, parent and child development. And when I looked on their website, I was interested to see that of all their clients, 78% live below the poverty level. 41% have children less than 4 years old, and 33% of their families live in doubled up households. So in an apartment, at least 2 families are living there. So Little Sisters of the Assumption, it was founded in 1958. It's a nonprofit. And again, they do home visits. They have on-site services, support groups. They really are an amazing, amazing organization. So after teaming up with them, what we did was we had pediatric residents on their advocacy rotation develop this prevention program for parents of children ages 0 to 4. We had a curriculum consisting of 10 modules, and we included topics such as feeding practices, division of responsibility, fruit and vegetable consumption, exercise and screen time. We also involved some nutrition students from Hunter College as well, and again, this was all IRB approved. So just as a quick digression, since this is medical education rounds, I just kind of wanted to talk about the advocacy rotation in pediatrics. So the ACGME requires that for pediatric residency, ambulatory experiences include some community pediatrics and child advocacy, must be 2 educational units. And the way that it's done here at Mount Sinai in pediatrics is that it's really integrated throughout all 3 years. It includes a walking tour of East Harlem during orientation for our pediatric residents. They have monthly advocacy noon conferences. They do Project Doc, which is delivery of chronic care. They visit families and children receiving chronic care to see how they live their lives. There is a 2-week advocacy block during the 2nd year ambulatory rotation, and our residents do visits to a variety of community-based organizations, including Little Sisters. They have some mentored advocacy projects and journal clubs, and then there's an option for scholarly focus in the 2nd and 3rd years. With the new ACGME requirements, everyone gets to have an individualized curriculum, and now there is a choice to focus in community pediatrics or advocacy, so they can spend some more time doing these things if they so desire. So kind of going back to the project, our classes were held in Spanish. They included recipe preparation and participatory exercise. You'll see some pictures coming up. And we did some pre and post surveys to assess changes in knowledge, attitude, and behavior. We had a nutritionist who was fluent in Spanish who actually ran the classes. She worked with the residents and with the other students to kind of put them together and run the classes. So here you can see some pictures from the classes. On the top left, you can see our nutritionist, Marilyn, doing some teaching about nutrition. You can see the families who would come with their children. And actually, as part of the money, we did have some babysitting services so that the mothers were able to pay attention as much as possible, even though at most classes you saw many little kids kind of running in and out and the mothers going in and out. On the other corner, you can see our participants exercising. We made sure that there was participatory exercise at each class, and we made sure that these were things that they could do at home. They didn't need any special things. They could use their chairs. It was okay to do in small spaces. And in blue, the person leading the exercise was one of the nutrition students. Here again on the top, you can see our residents being there and exercising along with the class. And on the bottom, you can see a picture from actually one of our last classes. The last class, we held a family meal, and all of the participants would actually make something at home and bring it using some of their knowledge that they learned and share what it meant to them, and everyone would eat together. So what were our results? So we held our pilot from May to July of 2014. We had 15 mother-child dyads begin, and 6 completed the course. So you see there was somewhat of a dropout rate. All the families were Hispanic and Medicaid recipients, and we found some consistent themes at the end. Their favorite parts were the recipe preparation and the exercise. They all planned on increasing their children's fruit and vegetable consumption, and they would all recommend the class to others. We learned quite a few things after doing the pilot. One of the things, because of the dropout rate, we knew that we needed something to keep these people in the class, to keep them interested, to keep them coming. We also learned that the survey that we first used needed to be a little bit more uniform, and so we made some tweaks for the next round. So the next round was held from October to December of 2014. We had 13 mother-child dyads begin, and still somewhat of a dropout rate, so we had 7 completing the course. Again, all the families were Hispanic. 69% of mothers did not complete high school. 77 participated in the WIC supplemental food program. And in this one, we did get the mother's BMI, and the average was 28.4, which, as we talked about earlier, is in the overweight category. We found that families eating together went from 38% to 86% at the end of the 10 weeks, which, when we did some statistics, trended towards significance. The number of TVs in the bedroom also decreased. The beginning, 85% had TVs in the bedroom, and at the end, 43%. One of the things that we also noted is that a lot of these families, the bedroom is the room. So, we do have to take that into account when we think about this question. We also found that the amount of children drinking 9 or more ounces of juice per day decreased. At the beginning, it was 23%, and by the end, it was 0. Now, this wasn't statistically significant, but we felt it might be clinically significant. And those eating fast food 2 or more times per week went from 31% to 14% at the end. All parents reported that they would recommend the class to others. 100% felt well prepared to feed their children at home compared to classes before. And the main themes identified include the importance of exercising and healthy eating. And again, you can see some pictures from the class, some recipe preparation. You can see that one of the classes was about different colors, and so they were introduced to some fruits and vegetables that they might not have had previously. We were able to present a lot of these findings in many different places, at many different conferences. And then we held our third round. So again, taking some of the things that we learned from the first 2 times, we made some more tweaks and held it again. So this was from April to June of this year. We had 19 dyads begin, and we had 15 completing the course, so we did better. In this round, we gave them some incentives. So after each class, they would receive some incentives such as cutting boards or other kitchen utensils, kitchen tools, things that we had talked about during the classes. All the families were Hispanic. All of them received WIC. 42% of the mothers did not complete high school. And 79% of them thought they were overweight or obese. The average BMI in this class was 26.9, again in 26.9, yes, in the overweight category. And here you can see a picture of our nutritionist doing the height while we were measuring BMIs. So our results here, 84% at the beginning and then 100% at the end knew there was a limit of juice set by the American Academy of Pediatrics. 63% down to 53% had a television in the bedroom, and 47 down to 20% got 1 or more hour of screen time per day. In this class, we use something called retrospective pre-post surveys. So this is a tool that's used to to assess how people feel at the beginning and the end of the class, but it's only given at the end of the class. So I should have put a picture of our questionnaire, which I didn't. But basically, we had our question in the middle. Do you feel, how comfortable do you feel feeding your child? On one side, we had pre-class, and on the other side, we had post-class. So this was, again, all done at the end of the 10 weeks. So it's been shown that this has some increased validity as opposed to asking the pre-question before at the beginning of the 10 weeks and the post-question after, right? You can imagine that before my talk, if you thought we asked you how much you knew about childhood obesity, some of you might have said, oh, I know a lot about it. But then at the end of my talk, if they asked you again how much you knew at the beginning, you might be like, oh, I didn't know as much as I thought I did, right? So this is a kind of a new kind of technique that we wanted to use. Again, some of the strengths include increased validity. There's the convenience of only doing it one time. It has a lot of versatility. Of course, there's still limitations, right? It's self-reported, and there's a recall period, right? You might not remember what you didn't know 10 weeks ago or however long ago you did it. So in our surveys, parents reported improved ability to recognize when their child is hungry, when their child is satisfied, to provide a balanced diet to their child, and to know what their child needs to be healthy. And when we did our statistics, all of this came out significant. So for this, we did write an abstract which was submitted to the American Pediatric Association, the Eastern Society for Pediatric Research, and Pediatric Academic Society. And we're in the midst of putting together a lessons learned paper to talk about all of these different rounds that we've done and what we've learned thus far. Here you can see some more pictures of some of our participants doing some recipe preparation that, again, they really enjoyed. The last piece of the project that I'd like to talk to you about is something called Photovoice, and something that we included in our last round of the project. So I like this quote from something that I found when I was looking up Photovoice. The heart of Photovoice is the intermingling of images and words. And really what it is you ask participants to take photos and tell their story related to whatever type of research you are doing. So what we did is we asked them to take photos of any barriers or obstacles to living a healthy lifestyle. It's a method used in participatory research to empower the members of the community to identify, represent, and enhance their community through a specific photographic technique. Some of the goals of Photovoice are to enable people to record and reflect their community's strengths and concerns, to promote critical dialogue and knowledge about important issues through large and small group discussion of the photographs, and even to reach policymakers. So there's some advantages of this, right? The participants gain some confidence, really feel as though they're participating in this research. There's increased knowledge for the researcher, right? Things that the researcher might never have known about. But there are some limitations. Not everyone might have access to a camera. They might not feel comfortable doing this. It involves somewhat of a time commitment, or at least remembering to do it when you go home. And they might have trouble representing their ideas that they want to get across. But we did have a lot of participants who took pictures, and at the end of the classes, we had shown them and tried to have a group discussion. So this one was from one of our participants. And when you look at this picture, what she really explained was that she was trying to get a picture of the bakery that you see on the left. Her husband actually works at the bakery. It's right in front of their house, and every day she passes by, and the smells are wonderful, and it tempts her. And so this was one of her obstacles to leading a healthy lifestyle. She tries to eat healthy, but it's very difficult. And even with it being next to the supermarket, I mean, it's right next door, she really had a hard time. And while we talked about this, it really started a discussion among the women. Another photo that one of the participants brought was this one. So what she was trying to get at were the stairs that you see right in front of the apartment building. And she was explaining how difficult it is for her to get up and down the stairs with her stroller and her small children. And it really limited her from going outside, especially in the winter. The last photo I'm going to show you is of this. This is an advertisement that this woman saw every day as she was passing by, and she found it really tempting. And when you have this in front of you, she found that it was so tempting, she was really unable to make some of the healthier choices that she wanted to make. Another photo that I don't have up here, but that we thought was really interesting, was a photo of a playground, but with men in the playground during the day. And what the participant was explaining was that she felt very uncomfortable going and bringing her young children to that playground, even though she wanted to give them exercise and playtime, because of the men that would just sit there, and it would make her very uncomfortable. So all of these things, all of these photos that we had seen really were things that we had never thought about, and really started some nice discussion among the participants on, them all agreeing, and then also coming up with things that they could do in order to kind of overcome some of these obstacles. So what's next? What's next for this project? So currently we're in the second week of our 4th round of classes. We had almost 20 participants at the first round, so we're really excited. We're using the incentives again, so hopefully we won't have much of a dropout rate like we did at the very beginning. We're using the retrospective pre-post surveys again. We're going to be using Photovoice again, so we're really hoping to get a lot of information at the end of this. We're also putting together the curriculum for dissemination. So now we have 10 weeks worth of curriculum, and so we're putting this together in hopes of bringing this to other community organizations, even putting it available for other places. We've gone to the school board, the New York City School Board, thinking if they might implement this program in the schools. And we also want to do train the trainers. So we have our nutritionist who's run the program multiple times, but we'd love to train other people in order to run the program in different locations. So I'd like to thank Leora McGillner for really mentoring me on this project, really helping to put a lot of this together. As you might know, she's an assistant professor in the Department of Pediatrics here. She runs the Advocacy Rotation. She runs Reach Out and Read. She's helped me. I don't know when she sleeps. So I do want to send her much of my thanks. And I also want to thank Marilyn Figueroa. She's the nutritionist that we work with. She's worked very hard on this. Heather Mitchell, who works at Little Sisters and has really helped with a lot of the logistics of our program. Rob Fowler, who I know couldn't be here today, but has helped us with our statistics. Little Sisters and all of the participants, the Mount Sinai Pediatric residents who helped to put this together, and of course the endocrinology team that I work with every day. Thank you.